So good evening and thanks to everyone for joining us today. We welcome and thank ISOPARB Prayagraj and Dr. Vandana Bansal, President ISOPARB Prayagraj, for making Jackson Pal Pharma the academic partners. Topic for today's session is Next Generation Gynecology, Epigenetics and Exosomes. So we now hand over this to Dr. Chitra Pandey ma'am to begin with the session.
Thanks, Nimisha. Good evening, everyone. On behalf of Team ISOPARB Prayagraj, I extend a warm welcome to all the dignitaries, esteemed faculty, and all the delegates on board. In today's webinar, we have two cutting-edge topics: epigenetics, which unravels how gene expression shapes health and diseases, and exosomal therapy, a futuristic treatment avenue in the field of gynecology. Before proceeding further, let us invoke Lord Shiva and take his blessings with the Mahamrityunjay chant. May Lord Shiva bless us with health, peace, and happiness. Now, I would like to invite our dynamic president, ISOPARB Prayagraj, Dr. Vandana Bansal ma'am, for her presidential address.
Thank you, Dr. Chitra.
Yes. Nimisha, display the CV of Vandana Bansal ma'am.
Distinguished guests, team speakers, members, and delegates. It is indeed my proud privilege today to welcome one and all in this special webinar on the future gynae. You know, everybody at this age is wanting to live long and healthy. So we thought, what should we choose our topic? So then we decided that to remain healthy, these two topics are very important. That is epigenetics and exosomes and stem cells. Because we thought that we are born with some genes. But now we know that even our genes can be changed by the environment, by surroundings. So that is very important for even the pregnancy, for the unborn child, for the maternity, for the health of the baby, for the future generation health. And the next topic we have chosen is the exosome. Exosome is a small vesicle responsible for cell-to-cell transmission. And it is a very new era, still unfolding. Lot of research is going on between the diagnostic, its role in the diagnosis and therapy. And already it is used in various modalities in the treatment. Ready-made exosomes are there. Exosomes can be, formed. We can form in the lab. So this also clears the our अपना जो ISOPARB का जो theme है for the maternal health and the future generation health, perinatology. So I am very happy. I welcome our chief guest, special chief guest, Dr. Sheila Mane, and she has her wonderful, work on the PPH. I always remember her. She excellently as a PPH person. I would like to introduce her. She is a ICOG chair elect. She is the vice president, FOXY 2014. She is the chairperson, Safe Motherhood Committee, president, BSOG 2005 and 6. She is the president, BMS Bangalore 2019 to 21. She is the national facilitator, adolescent health, ICOG governing council member 20 to 22, ex-president, Bangalore Menopause Society, President ISOPARB Bangalore chapter at the moment, and she is the reviewer of JOGI, faculty FIGO PPH stimulation workshop. She is very dynamic, always on the work, and you can see her everywhere from the menopause to ISOPARB to FOXY. Name a place and she is there. Welcome, ma'am. And our next guest of honor, she is here, Chitra.
No, ma'am, still she has not joined.
So we are waiting for her.
Yeah.
So when she comes, then you introduce her. And I'm thrilled to have such speakers with us like Ragini Di. Ragini Di is so close to my heart. She is always a Didi. And her connection with me is emotional, not professional. She was always there with my, the Menopause National Conference. She was the one who told us, no, you can do, you should do, you know. And our next speaker, Dr. Prabhu Mishra. Dr. Prabhu is my, guide also. I did fellowship under him, and she is an excellent teacher and excellent person. I don't know what his brain is, and he is traveling all over the world. This longevity conference, and he has patented so many things. So we have such fabulous speakers with us today. So I'm sure everyone is going to benefit by this, because small things which we gain makes a big difference in the tomorrow generations. So let us all welcome this webinar. And Chitra, will you wait for the guest of honor, or will you start now?
Okay, I'll
Lectures?
just tell you.
Take blessings of Dr.
Please
Sheila.
start. Please start.
Now
with
I
Sheila.
request our chief guest, Dr. Sheila Mane ma'am, to say
Yeah,
a few
she
words
will.
of
She will
blessings.
say a few words. Then we'll start.
Yes. After that, we will start scientific session.
Sure. So we request Dr. Sheila Mane, please, to say a few blessing words for the today's webinar.
I think, yeah, ma'am is joining.
She is there.
Where's
Yes.
Sheila gone?
No, she is here. She is here only.
ये लो जी, आपने बोला वो सच में चली गई.
No, actually she was trying, I think.
No, she was there, very much there.
She was there. She was.
Chitra, Dr. Prakhya is joining, but she will not be on the video. She is switching on her audio. She's just joining.
Okay.
You can introduce her, Chitra. Doctor.
Let her join only then I will.
Let Sheila first come in, na?
Where is she?
Ring her up. Anjula just called Sheila.
Suddenly did she discontinue?
I'm calling her.
Maybe she's unable to join or something.
She has rejoined. Yeah.
Am I audible now? Am I audible?
Yeah.
Yeah,
You are
Thank
audible.
you. And sorry. Okay. So I can see all seniors from Allahabad, and I always appreciate Prayagraj for such vibrant activities, whatever you do. Okay, it is so vibrant. I still have the memories of last IMS. Okay. Very fresh. So Dr. Manju Verma, Dr. Veena Gupta, Dr. Anjula, Dr. Chitra, Dr. Vandana. I think you're doing the best part of it. And I would really like to congratulate you session, and what such good topics you people have selected, that is epigenetics and then exosomes. I think this is becoming very important for us, because we know that the endocrine busters are around us, and that is disturbing. And it is very important that the future generation's health is in our hands now. And really we have to act now. If we don't act now, all of us, we know that it will be a disaster. The NCD is on the rise. And in our practice also, we are facing so many problems now, that the anti-obesity drugs have come in now to that extent, the young girls, reproductive age group, they are putting on weight and giving rise to so many problems. So I think epigenetics plays a role there, and the exosomes, where we have to learn that how should be our lifestyle, so that, the longevity can be there. And that too, longevity is not only important, the person should be healthy. We know the life expectancy of the woman has gone up. That is true. But what is important is that all of them have to learn a healthy life, And if we have to start it now, we should start it now. And I think we should first preach at home. So all our young talent and young obstetricians and gynecologists should start following it, so that, they will be really healthy, and then they will themselves give a message to the society. So it's a very, very important topic, and I congratulate everybody. Dr. Ranjana Khanna, I still remember my visit to Allahabad, how we troubled her, accommodation, kahan pahunchna hai, kisko bulana hai, how to go to Ghat. So there are so many. Dr. Manju Verma, I still remember visiting the Sun Temple with you in Allahabad, and so many memories I have, all of you. So thank you very much for inviting me and giving me this opportunity to see all of you virtually and to interact with you. And that gives me so much of pleasure and happiness. Namaskar. Thank you.
Thank you so much, ma'am, for your words of blessing. Now, we would like to invite our guest of honor, Dr. Pragya Mishra Chaudhary, a very dynamic person. I think madam has already joined. Dr. Pragya is Secretary General of ISOPARB. She is a consultant infertility specialist at New Life Test Tube Baby Center and MGM Hospital and Research Center, Patna. She's chairperson, Genetic and Fetal Medicine Committee, 2016 to 18, founder secretary of Bihar chapter of ISAR, RCOG co-opted East Zone Fellow Representative, 2025 to 2027, examiner for MRCOG clinical examination, and she also imparts FOXY certified colposcopy training. She has many awards and accolades to her credit. She was awarded Asia GCC Award 2021 for Excellence and Leadership in IVF Gynecology, awarded Healthcare Professional of the Year 2018, Bihar Gynecologist, awarded the George Mahoney Award 2014 by the RCOG. And she has organized many conferences. She was organizing secretary 10th National Yuva ISAR 2024, organizing secretary of FOXY LabourCon 2023 Patna. We welcome you, ma'am, and we would like to listen few words from you, few words of wisdom.
Yeah. Hello.
Hello. Yes, ma'am. We can hear you.
A very good afternoon to all of you.
and video on karo.
I just apologize to Dr. Chitra Pandey that I will have my audio. I won't be. I will log in. I will switch on my video in a little while.
Okay.
So at the outset, I would really like to congratulate Prayagraj chapter of ISOPARB, which has been really, I'm not trying to flatter, but it is a fact that it is one of the ISOPARB chapters in the country which has been doing very well right from the start. Dr. Ranjana Khanna is the founder, chairperson of this chapter, and this scientific sangam she had been doing consistently every 2 months, if I'm not wrong.
No,
and
every month.
Every month, and it almost went up to 30 something as far as my memory goes.
Yeah.
30, because 35, 36 I did present in one of the conferences also. So I mean, it's really heartening, to see, because I'm from the head office, Patna, and to see ISOPARB flourish like this, and people, especially in the North Zone, now taking so much of interest and actively participating in ISOPARB activities. It's really thrilling. And Dr. Chitra Pandey, I know she has, and of course, our chief guest, Dr. Sheila Mane, I did hear speaking such good words about Prayagraj and Allahabad. And the same conference, even I remember that, I reached almost at 1 a.m. in the morning, or you can call it at night, that conference which you had organized so wonderfully in Allahabad IMA building. It was quite nice. And that time, Dr. Manju Verma was also there to receive me so open-heartedly. Now, Dr. Chitra Pandey, like personally, only recently I've known her, but I had been seeing her work very hard, because for UPCOG, the first time I think it was, if I'm not wrong, Dr. Chitra, I think you compared in one of the UPCOGs. Is that right?
Yes, ma'am. I was there.
So
Yes.
Yeah.
Not
So
not UPCOG. You did not
That
compare
was
in that. You compared in SEVMA.
SEVMA first.
Hmm.
SEVMA. That was
That
okay.
was a
So,
National
but
Foxy Conference.
yeah,
2000. That
but
was in 2016.
16.
Yes.
Right.
because I was chairperson that time and I was like, moving around. And so, but I've been observing you work very hard for the last so many years.
Yeah.
And so, and today's topic again, every time you all come up with a new theme. And today, well, we used to say earlier, it's all in the genes. But really, it's not just all about the genes. It's about the epigenes also, the epigenetics. And because environment plays a lot of role in the early embryonic days and the fetus, when the fetus grows inside. So a lot like nutrition and other things. And when I remember Dr. Jaideep Malhotra was the Foxy president, we used to talk about so much of how the fetus even has that sense about the environment and in which it is growing. Right now, I cannot recollect that exact caption, which was
Adbhut Matritva.
and Adbhut Matritva, yes, that was the Abhiyan. But, there was a particular terminology which they were using for the fetus, about the senses which the fetus has. It's not just about nutrition, it's all about other things also. So fetus in itself is like a human being. I mean, it's
Yeah.
yeah. So and when we talk about fetal origin of adult onset disease, that also, I mean, well, it's all about epigenetics. And now that we see, well, earlier they said the Indian subcontinent is the diabetic capital of the world, and now well, other things also, like other like hypertension, thyroid, etc. For these also, the numbers are rising so much. So basically it all means that right from the time that the fetus is in utero, we have to pay attention for the welfare, for the overall. So that's where epigenes come into play. And I'm quite eager to listen to the talks that you all are going to have today regarding epigenes. So thank you so much for remembering me time and again. So thank you so much for having me today as guest of honor. And I looked at the program and the two talks. I think really are going to be worth listening and worth learning from. And so thank all the people who are involved, the conveners and and all the chairpersons for this program. And thank you very much, Prayagraj chapter. Keep up the good work. And I'm sure very soon you would also be getting the chance to organize an ISOPARB conference in the near future. Thank you so much for having me.
Thank you. Thank you so much, ma'am, for the pearls of wisdom. And now we would start our scientific session. And our first scientific session, the speaker is brilliant and our very own Dr. Ragini Agarwal, ma'am, and she will be speaking on endocrine disrupting chemicals and epigenetics regulations in embryonic development. I would like to invite chairpersons for the session, Dr. Sharda Nimisha. Display the CVs of chairpersons, please. Dr. Sharda Chandra, ma'am, she is senior obstetrician and gynecologist in Prayagraj. She is director and consultant of JC Maternity Center Prayagraj, and she is also former vice president of Allahabad Obs and Gynae Society. Very active member and very graceful. And welcome, ma'am. And our second chairperson is Dr. Amrita Chaurasia. Dr. Amrita is professor and head Department of OBGY, MLN Medical College. She's also convener of Institutional Ethics Committee, MLN Medical College, Prayagraj. And she has published many papers in national and international journals. And she has also written chapters on unveiling origin of PCOS and ectopic pregnancy. She has many awards to her credit. And right now she is busy in the exams, so she might join later. But and
I think she has already joined.
welcome,
वही
Dr.
मैंने कहा she's already joined.
I may leave early. Sorry for that.
No, no, no. Thank you so much. At least you are able to join. And now with absolute pleasure, and it's with pride, I invite our expert of the session, Dr. Manju Verma, ma'am. Madam is our teacher, mentor, guiding light, everything for us. So, Madam is past president, UP chapter, Obstetrics and Gynecology.
चित्रा समय नहीं बर्बाद करो, सबको मालूम है, आगे बढ़ो.
Thank you, ma'am. Thank you so much. So now I would request Dr. Sharda ma'am to introduce our speaker to the audience. Dr. Sharda Chandra ma'am, please.
अमृता को बोल दो. Sharda is there.
Yeah.
Sharda ma'am, your mic is mute.
No, yes, she's
I think,
very much here.
इलाहाबाद की
Ma'am, please unmute yourself. Sharda ma'am,
Is
please
it okay?
unmute.
Can you hear me?
Yes.
Yeah.
Okay, good evening, everyone. Today I have the privilege of introducing our speaker, Dr. Ragini Agarwal, MS, FICOG, FICMCH. She is Fellow Clinical Gynae Endoscopy UK, Aesthetic and Functional Regenerative Gynecology, Female Sexual Health Specialist, Director AA Dharma Science Complete Clinic for Women's Health, Her Life Matters, Gurgaon. She is now Secretary General IMS 2025 and she has been Founder Chair Aesthetic Health Committee IMS 2020-2022. She was Joint Secretary IMS 2023.
काफी है.
Menopause Society Gurgaon.
रागिनी हमारी अपनी ही है.
Few awards she has to her credit: Best Committee Chairperson IMS 2022, and she has many publications. She has contributed chapters and articles in many books and journals and social awareness magazines. She has authored many e-books on different aspects of menopause. Latest is How to Set Up a Menopause Clinic. And she has organized North Zone IMS Conference and National IMS Con in Gurgaon, e-conferences on menopause, and menopause marathon involving all societies and leaders of menopause medicine field to spread insight on subject. First e-course on menopause to spread knowledge to all practitioners beyond IMS members, 8 modules, many e-public forums on subject of menopause. She has keen interest on all aspects of women's health. Welcome, madam. We are awaiting your
Thank you so much, Dr. Sharda. इलाहाबाद में मेरे इस इंट्रोडक्शन की कोई जरूरत नहीं है. वेरी गुड इवनिंग टू वन एंड ऑल. और सबसे पहले मैं डॉक्टर मंजू मैडम को नमस्कार करती हूँ. इलाहाबाद मेरे लिए कोई अनजान नहीं हो, मैं इलाहाबाद के लिए अनजान है. थैंक यू वंदना एंड चित्रा फॉर गिविंग मी दिस अपॉर्चुनिटी. एंड रंजा जी तो खैर बुलाती ही रहती हैं. सो heartening to come ever always to Allahabad. So coming to directly to topic, with the blessing of God and gratitude to one and all, this topic is little different as we have discussed that endocrine disrupting chemical, how they are having a havoc on the developing fetus. So we are going to talk about the mechanism, impacts, and the emerging trends. Friends, for us Indians, this is not something new. The माँ और गर्भस्थ शिशु के संवाद को, उस पे पूरी महाभारत का चक्रव्यूह अटका हुआ है. And it was very clear to us there is something which changed inside the baby. And the second saying of in our Indians कि आप जैसा खाओगे वैसा ही बच्चा पैदा करोगे. So these two things are always in our culture, and now it was accepted by the scientists, all Western scientists also. So we are discussing here epigenetic. During pregnancy, hormonal regulation replaces genetic control in many aspects of the fetal development. And any disruption in this level can have a downstream consequences for organ formation, neurodevelopment, and the lifelong health. Why we are going to discuss it? Because more than 800 ATCs are identified, and prenatal exposure is the most vulnerable window, leading to the increased burden of the reproductive and the developmental disorders. Ubiquity of the synthetic chemicals in daily life is really playing a havoc, Epigenetics now understood as the key link between the exposure and lifelong outcomes. Embryonic development is highly hormone sensitive and regulated by the maternal placental fetal endocrine axis. We all know that placenta is the biggest endocrine organ in our body, and it produces many key hormones like SCG, progesterone, estrogen, HPL, and day out, day in, every year we come across some new enzymes or some new products which is produced by the placenta, and it plays a great role in the development of the comorbidities or the obstetrical complications, or their ratio can change your way of management also. So when we see this maternal fetal placental axis, basically these hormones support organogenesis, sex differentiation, and growth and metabolic regulations. And this is a dynamic feed loop. Even minor endocrine disruption in early stage can permanently reprogram fetal physiology. So what is the endocrine disrupting chemicals? Basically, these are the exogenous substance or mixture that interfere with the hormone action in the body. When we see them, they are in our daily life. No doubt plastics like bisphenol and phthalates, they top the list. And this phthalate is in your nail paint also. So remember, a antenatal patient having a nail paint, she is going to absorb phthalate throughout the pregnancy. And all cosmetics having lots of parabens and other products also, then pesticide, herbicide is non-modifiable nowadays. There are industrial chemicals, personal care products, food packaging, thermal resin. They either mimic the natural hormone or block the receptor binding, alter the hormone metabolism and the synthesis, and in developing fetus lead to the epigenetic modulation, which is a transgenerational effect. So low dose exposure, this critical window of the first trimester, may have non-linear or the latent effects. So if you see this diagram, basically genes load the gun and environment pulls the trigger. Everywhere we are surrounded by these endocrine disruptor chemicals. Epigenetics is how the environment write instruction on the DNA blueprint. Unlike mutation, these changes do not alter the genetic code, but they do alter its expression, sometimes permanently. Means बच्चे की जन्म पत्री वहीं पर लिख जाती है कि आगे जाकर क्या होगा. We all know that the embryogenesis is a critical period because the cells are totipotent and there's a lineage commitment leading to the organ-specific gene expression. And these three are the main key epigenetic mechanism. Whenever we read about anything genome or any changes in the DNA or exosome sequencing, so these three words come one by one. One is DNA methylation. Another, which is very important, is a histone modification, which modify the chromatin structure. And DNA methylation is crucial for imprinting. Then third thing is a non-coding RNAs, that is miRNA, which regulate post-transcriptional gene expression. So I will not go in detail in this slide, but in nutshell, I can say when there's a DNA methylation or histone post-translation modification, there's a change in the regulation of imprinting, there's a change in the gene expression or chromatin remodeling. And these all things, imprinting, RNA system, they will lead to parental or genomic imprinting control. And not only this, this process will go as a imprinting maintenance in the transgenerational to one mother, nani to beti. Sorry, natin. So this epigenome is most development and changes can persist through life or across the generation because they can lead to developmental plasticity. We have to understand the developing brain, specifically amygdala and the hippocampus, which has a neurocognitive control. Its developing plasticity, if changed, will lead to a autism spectrum, to the ADHD behavior and whatnot. Not only there's a permanent alteration in the organ function, we all are seeing the epidemic of the PCOD and predisposition to the adult diseases, which concept we every time we talk when we talk about these Baker hypothesis. So this endocrine system works on the precise chemical signaling, and these chemicals introduce noise and distortion into these signals, especially during embryonic development when cells are highly responsive. These signals, when go to the proper receptors, they either mimic the natural hormone, that is the agonistic effect, like BPA binds to the estrogen receptor, blocking receptor, that is antagonist effect, like phthalate block the androgen receptors, altering hormone synthesis to metabolism and interfering with the hormone transport proteins. It can alter epigenetic regulation, leading to aberrant DNA methylation, histone acetylation, and disruption of the non-coding RNA expression, which I have already explained in detail. And these persistent gene dysregulation affect cell differentiation, organ morphogenesis, and metabolic programming. So basically what I told you कि जन्म पत्री जो है लिख गई पूरी की पूरी, and here what happened, this methylation and these epigenetic alteration may not manifest at birth, but can lead to lifelong health consequences or predisposition to adult disease. Many a time, these mental disorders like conditions appear in the adults, and this ADHD, adult ADHD, has its seed in the womb only. So this most ADHD is allowing passive diffusion across the placenta. Placenta is not a perfect barrier, as it has a limited ability to metabolize or block the chemicals, as we very clearly know that placenta is able to block the cortisol up to one limit, but after that the all cortisol go to the brain of the baby, and this continuous stress can change the plasticity of the developing baby. So like this, all the ADCs can accumulate in the different kind of the fetal tissue, and vulnerability is highest in the early gestation before full placental maturity. And it has an irreversible effect depending on gametogenesis, as a germ cell epigenome remodeling, implantation, and the placentation between 21 to 56 days organogenesis, sexual differentiation between week 7 to 20, neurodevelopment, and continuous postnatally may remain subclinical until the adolescence or the adulthood. Now, these hormone limitations or blockade can alter sexual differentiation, gonadal development, and the later reproductive health, doing a hormonal hijacking because they act as a estrogen or the androgen. Estrogenic mimicking EDCs are BPA, PCBs, which bind the estrogen receptor, causes feminization and uterine changes. Anti-androgenic EDCs, phthalates and vincologin, block androgen receptor, lead to male genital malformation. DDT and its metabolite, because of the both dual action, they can also cause the problems. They can induce epigenetic reprogramming during critical reconfiguration phase, silencing or overexpression of the key developmental genes, and alter fetal growth, immune programming, and HPA axis. If you see it, these clinical outcomes may be in the term of the asthma, neurodevelopment, neural tube defects, birth weight problems, immune and metabolic disorders. Even so much cancer is there, here also they play a very big role. EPA exposure linked to the insulin resistance via epigenetic changes in pancreatic beta cell. And we all know the base of the PCOD is the insulin resistance. Now, diabetes mellitus type 2 is an insulin resistant disease. The metabolic syndrome is an insulin resistant disease. So what I was talking about, the heritable epigenetic disruption, these legacy effects of exposure may ripple through generation. Multi-generation effect is seen from the exposed mother to fetus to the second generation fetus development. And famous model is, there was a mice, then in that this experiment was done with the coat color and the obesity influenced by the maternal BPA and the methyl donors, and it has a implication for the population health and the reproductive trends. So these are the chemicals which I have talked in detail, and we see what not they can do. They have a effect as a reproductive anomaly, obesity, thyroid dysfunction, cognitive delay, and infertility, which is increasing day by day. Now, if it has between the 7 to 12 days, what happened? There's a cases of the cryptorchidism, hypospadias, and the Mullerian anomalies in the female, like these exposure you can see. And it is a critical window which we have to see for the hormone-dependent organogenesis. So real environment, if you see in this particular diagram, there's everything from air pollution to your occupational exposure. There's a mixture which goes inside and causes organ level to individual level to population level changes in your body. The brain development affect a lot because it associated with the autism spectrum disorder, ADHD, reduced attention span, lower IQ, memory impairments, and it is basically a start from the thyroid hormone disruption to the altered expression of the neurodevelopment genes. The prenatal ETC exposure linked to anarchy and thelarchy, involuntary cycles in the adolescence, and the polycystic ovary syndrome like phenotypes, altered kisspeptin and the GnRH pulsatile leading to the many type of the infertility problems. This EDC impair placental development and the nutrient transport, and it results in the IUGR. Many a time it is really mind-boggling after all antenatal care, such a good nutrition. Even the upper strata patient, they also get the IUGR babies. Why it is? There are lots of studies have come up where they have found the nanoparticle of the plastics inside the placental channel and in the brain of the baby. So these epigenetic changes in the placental implicated genes are IGF2, H19. They alter fat cell development also, promote adipocyte differentiation via PPARY pathway, and this epigenetic dysregulation in genes controlling insulin sensitivity, appetite, fat storage, and fits in the thrifty phenotype hypothesis that fetal adaptation will lead to the adult metabolic disease. We all know that the thyroid hormone are critical for the brain development and the metabolism. Again, these disrupt this thyroid axis also, block iodine uptake, disrupt TSH, T4, T3 synthesis and binding, leading to the neurocognitive deficit and delayed language and the motor skills. Not only this, nowadays we are seeing somehow the endometriosis is increasing like anything. So these are basically particularly dioxin alter the uterine gene expression, and the epigenetic modification of the HOXA10 ESR1 WET genes altered uterine receptivity, increased susceptibility to the endometriosis. Because you know these EDCs basically act as a genoestrogen inside the body. Their structure is very similar to estrogen. So inside the body, they are increasing all the time the estrogen exposure to the cells. Cancer predisposition is also increased. They are linked with the breast cancer, prostate cancer, testicular cancer, and mechanism is silencing of the tumor suppressor gene and the long-term dysregulation of the hormonal control pathways. There's a lots of advance in the epigenetic testing has come. Next generation sequencing, placental tissue as a non-invasive biomarker source, and EDC-related methylation signature linked to the imprinted genes, and emerging clinical utility in risk prediction and the stratification, which we are using specifically in the cases of the preeclampsia with the SFLT ratio. Again, there are lots of things in the development research. There are 3D organoid in the placenta on a chip model. The placenta on a chip is a platform to simulate the maternal fetal interface. Human specific response to the EDC, you can see ethical, reproducible, and real-time monitoring, and it will bridge gap between the animal studies and the human relevance. AI is everywhere. The AI model trained on the chemical structure databases, toxigenomic profiles, epigenomic datasets, and the predictive tools can identify high-risk compounds before clinical use or integrate exposure data with the disease outcomes. So how we have to tailor the prevention from the womb? Personalized prenatal care model, environmental exposure history, as we take all the histories, family history, medical history. I think that it's a time when we start adding the environmental exposure history also. And we take 2 minutes to discuss with our patient that what you are taking, all the takeaways, they are coming in the wrong type of the plastics. Even your disposables, they have the glue and inside the plastic lining. And empower decision making through environmental counseling and the safer lifestyle, the product substitution. Certain nutrients modulates epigenetic response to EDCs like folate, choline, B12, and we know they are the good molecules. Maternal diets can buffer or exacerbate EDC toxicity. So the scope of the nutrition intervention in at-risk pregnancy is there. We have to tell them that don't take the tin canned foods, instant food, trans fat food like Maggie. They are so fond of Maggie. So we have to design hormone and the safe future, push for the EDC-free alternatives, green chemistry principles, and but the BPA-free often replaced with the BPS or BPF is still endocrine active, and importance for the rigorous safety testing for the substitutes. There's a lots of future research direction is there, multi-omics integration, feature programming studies, in vitro new approach methodology, and the call for the updated regulatory framework. But what is most important is your own clinical counseling to the pregnant woman. Like avoid plastic container, choose fresh produce, avoid cosmetics with parabens, phthalates, triclosan, all those sunscreen. I always tell my patient to use the zinc oxide, change your cosmetic to the shea butter, glycerine, and Vaseline. Lots of aromatic oils are also come, but you have to see which is allowed in the pregnancy or not. Minimize use of the air fresheners, scented candles, no to deos and the your perfumes. Prefer BPA free but verify substitute and promote label reading habits. There's a bio oil for pregnancy stress mark is there in the market. If you see, there's a long list of small chemicals, and they are all obsolete in the Europe for last more than 10 to 15 years. So you clinician are the health advocate, first point of contact, environmental history taking, preconception counseling in every antenatal visit, tell about the EDCs, lead initiative as the community talk, integration with the pediatrician and the public health teams, and specifically, we have to go for the institutional changes. To summarize, from mechanism to maternal action, mechanism EDCs interfere with the hormone receptor, and they are the critical embryonic window where they can have a havoc. There's a long-term reproductive, neurodevelopmental, and the metabolic consequences. Multi and the transgeneration effects are now documented. OBGYN, we are the primary physician to the woman. We are uniquely placed to screen, counsel, and advocate. Need for the interdisciplinary collaboration between the clinician, scientist, and the policymaker. This is my last slide. We are not only treating the present mother, but also shaping the biology of the future generation. Thank you so much for your patient hearing and to give me this opportunity.
Excellent, Dr. Ragini. Excellent presentation. As always.
रागनी दीदी बोला करो भाई.
अच्छा, रागनी दी. Ragini Didi, bilkul. Always, as always, very important topic. We should know. Actually, all pregnant women and couple, not women, couple should go for a healthy lifestyle 3 months before conception. So it takes 3 months for the epigenetics to change, and it is a good practice in India. In fact, in Ayurveda, they say that they should go for, Ayurvedic treatment, detoxification, and lead a Ayurvedic way of life. Then the progeny will be born, will be very, adhyatmic and good.
Thank you, ma'am. I would request Dr. Manju Verma, ma'am, to give her expert opinion.
Thank you, everyone. Thank my heartfelt thanks to Vandana and the whole organizing team. Very, very good evening. And Ragini, should I call you Ragini Didi?
नहीं आप मैडम बच्चा हूँ.
No, so Ragini, you are always, coming up with something new, something very complicated, and something very useful. Your talks are always like that only. And as you have already said during your talk, that the changes that occur during the embryonic phase of pregnancy, whether it is cleavage, blastula, gastrulation, or organogenesis, everything is being affected by particles. And these particles should be avoided as far as possible during pregnancy. Now, one thing people should understand, there's something called genetics and the other is epigenetics. Genetics is basically the gene structure, the DNA structure. So if the DNA structure is changed like by mutation or by deletion, then it is a different thing. But if the function of the DNA or genes are being altered, then it becomes epigenetics. They don't change the gene sequence or anything else, but they change actually by methylation or by other chemical reactions, that the action of the genes are being altered. So this is something which is being coming up very recently, and all these EDCs, they should always be avoided during pregnancy, not only during pregnancy, as far as possible throughout the life, so that the changes that can occur can be avoided. This has now been implicated into neurodevelopment, PCO, FGR, then endometriosis, and even cancers. So the future of actually of this topic is that how we can, in the embryonic phase, change the likely risk prediction, and you can change how you can avoid the complication that can occur later in life. So thank you, Ragini. Very, very nicely explained. Very, very vividly, clarified. Thank you, Ragini. Thank you very much. Thank you.
In end, I only want to say one thing. We should start. I do. मेरे तो बहुत सारे patient भाग भी गया, बहुत preaching करती हैं. लेकिन it is our duty to tell them not to use these things.
Hello.
Ranjana ma'am, would you like to add something? Please unmute yourself.
Yeah, Ragini, that was a wonderful talk. And I remember when I did my conference, BOH, the Triology in Delhi, in Gurgaon, I had done it in Leela.
2017.
That is 2017, when I was the vice president of Foxy. So then my friend, she was head of the Department of Gynae in Saudi. So she told me that there's a lot of work going on in epigenetics, and environment plays a lot of role. Dr. Purnima Deb, then she flew in from there and she gave this keynote address, and it was very much appreciated. So from that time, the role had started all over, and now we are getting more and more of it. And especially Delhi becomes so congested and so polluted. So I think the Delhi people are getting more and more aware of their epigenetics. But we should, yes, it is very important, and small things. Like the other day, somebody was saying about we should be careful about the lipsticks that we put on, because there's so much lead in them. There can be lead,
It's
and
supposed to be
that
a
is leading to
bomb.
slow lead
Lead bomb.
poisoning also. So we have, these are small things. I don't think at least I have never read on a lipstick what are the constituents. So that is why we don't come to know. Maybe it's there in black and white, but we don't know about it. So we are using lipsticks left, right, and center. So which
Have
type
stopped using all
affects
the
what?
cosmetics.
And then we sit and eat food also with that. So naturally, part of it is going inside only our stomach. So we don't know how much harm we are actually doing.
Especially
Ranjana?
mugs, they are glasses. They really are going, distributing so much of plastic into the body. That is
Yes.
really bad. One should never take those plastic glasses or
Those
Yeah,
small
plastic.
plastic glasses, they serve tea in that, then it's
Yeah,
That is very bad. That is very bad. And you
that
know,
is why
कुल्हड़
Modi ji
मिट्टी का
stresses on
कुल्हड़ लो.
kullhad, na? Modi ji
Kullad is
always
the
stresses on kullhad chai.
अच्छा, आज मोदी जी की बर्थडे है आज.
I know.
मोदी जी जो करे तो ठीक है, पर हम भी कुछ कर सकते हैं ना.
Bilkul.
These days tests are available. Epigenetic tests are available in India.
Yeah,
There's
yeah.
something
Yes.
called Map My Genome. So they do the whole epigenetic test.
वो तो बात की बात होगी ना प्रभु. सवाल तो ये है,
सवाल
एपिजेनेटिक्स की अगर
पहले से
कहानी लिखी गई तो फिर लिखी कहानी का क्या बदलोगे?
हाँ.
Thank you.
Bilkul.
Thank you
Anyway,
so much.
genetics is the 20%, 80% is the stochastic factors.
Yes, true. It goes through that only mostly.
चल.
Lungs and stomach.
And the other day I was reading in the papers that they have discovered tons and tons of plastic in the oceans.
In the
And
body.
now they are
Yes.
trying by
In
machines
the
to get
bodies
out.
also. In the animal bodies, in the cows.
So
Cows ke
sad. It is really.
jo
In
milk,
cows,
whatever the milk we are
so many
consuming.
times intestinal obstruction takes place in cows.
Before moving to Prabhu,
Yeah.
I just want to add one more thing जो मुझे आजकल सबसे ज्यादा परेशान कर रहा है. बाकी चीजें तो मैंने छोड़ दी. सिंटेक्स की टैंक का क्या करूं?
हाँ.
Very true.
किसका
Very
किसका
सिंटेक्स की
टैंक
टैंक.
का क्या करोगे? सबके घर में तो ऊपर प्लास्टिक
पानी वहीं से
की
आता है.
लगी हुई है.
अब वो गर्म
So
होता है उसका.
true, so true.
So
No,
many
हमारे
things.
घर में कोई plastic tap नहीं है.
Microwave you are
मिट्टी वाले.
using. आप
नहीं मैम, आप
So
मैम वो
many things
टैंक
there.
जो होता है, पानी वाला टैंक.
टैंक तो सिंटेक्स का ही है.
You know,
हाँ.
Thanks
टैंक
everyone
तो
for the
सिंटेक्स का ही
valuable
है.
input.
there is no end. You can go
Now we
on.
proceed. Now we
पहले
proceed.
जमाने में सीमेंट के होते थे ना.
सीमेंट के होते थे और हम लोग के पुराने
हाँ.
घर में वही हैं.
क्या
नहीं,
चित्रा?
हमारे तो सिंटेक्स आ गया है वापस.
चलो प्रभु.
Thanks everyone for the valuable inputs. Now we will proceed for the
Dr.
next.
Chitra,
And-
Dr. Pragya Mishra this side.
Yes,
It was just just 2 minutes, just wanted to interrupt. Actually,
Yeah.
it was a very nice talk by Dr. Ragini Agarwal, with regards to epigenetics and endocrine disruptors. Dr. Ragini, it was very nice. I hope you can, you are there?
प्रज्ञा तो मैं
Yeah,
अंदर के
yeah,
आंखों से
she's
देख
there.
रही हूँ तब से.
She's
अंदर
very
की
much
आंखों से
here,
देख
ma'am.
रही हूँ.
She's here.
So actually, I would really like to congratulate the current president of ISOPARB Prayagraj chapter, Dr. Vandana Bansal. I know she's very active in other societies also, like Indian Menopause Society and Fertility Societies, and she has strong connections with Patna also. I think, Dr. Vandana, I'm right.
Yeah.
think,
You're
Masters.
definitely. I'm from Patna. Thank you very much.
Yeah, and I think my mother was an examiner or something.
Yeah. My examiner, she was in DQ. Yeah.
Yeah. So I think you really curated a wonderful program. So I would really, along with you, I would like to congratulate the scientific secretary also, Dr. Manisha
Yeah.
Gupta. So just keep up the good work of Prayagraj chapter, because it has been doing very well, and it should just keep on doing very well and and hold a prominent place in the ISOPARB national front. So really congratulate you for this coming up with this different subject, on epigenetics and endocrine disruptors. And the guest speaker, Dr. Prabhu Chandra Mishra, I think we are going to learn a lot from him also regarding exosomes therapy. And the chairpersons also for that session, Dr. Veena Gupta, Dr. Amita Tripathi. So all of them, all friends, we will be seeing them very soon.
Thank you. Thank you so much.
Thank you so much, ma'am. Now, moving to the next session, I hand over the proceedings to Dr. Manisha Gupta. Madam is Scientific Secretary of ISOPARB, and she was also Vice President of Allahabad OBGYN Society from 21 to 24. Over to you, Dr. Manisha.
Thank you, Chitra. Good evening, everyone, and namaskar to my all seniors and teachers. Now, first of all, I'd like to say that Ragni Di nicely explained us about the epigenetics, जो हम लोग वर्च्यू बेबी के बारे में हमेशा से सुनते हैं कि कृष्ण जी की फोटो लगा लो तो भाई अच्छे environmental अच्छी vibes आएंगी. Similarly, now we have Dr. Prabhu to speak about exosomes. जैसे हमारे chromosomes हैं, which are naturally made with the DNA strands. Similarly, we are now working at a at a molecular and intracellular level to like modify some changes which we can do in the gynecological diseases like PCO. Then we have endometriosis or other like chronic diseases where we can even in malignancies they are trying to like change the internal milieu of the cell. Like initially they were stem cells to regenerate new cells. But now what we are doing, we are trying to change the internal milieu of the cell. And Dr. Prabhu will definitely speak and like enlighten us on this topic. Then we have a very senior expert with us, Dr. Anjana, who doesn't need any introduction, but only I'll tell that she's an executive member of a national ISOPARB and founder member of ISOPARB for Allahabad. And it was her effort and like it was her brainchild to develop ISOPARB at Allahabad. Then she has been a president of AOJS Allahabad for many years and VP of Foxy. We all know she has organized so many nice conferences starting from SEVMA, then POH Triology, then Obstetric Dilemmas, Sangam, Scientific Sangam was the last one. And I think now after Kumbh she'll again be active in the coming time and give everyone the like chance to come come and see the new Prayagraj. Then she has many awards to her credit: the Thira Award, Foxy Achiever Award, then Smriti Milan, and so many awards. Then she has authored many articles and chapters in various journals and books, and she's a co-convener in Foxy GCPR for epilepsy treatment during pregnancy. So then we have our two chairpersons, Dr. Amita Tripathi, जिसको कि कहना चाहिए लोग कहते हैं कि हमारा बायां हाथ या दाहिना हाथ तो she is I think both hands for Dr. Anjana ma'am. And similarly, she is equally such an active and apart from being so active, in spite of being so active, she is always so cool and so organized in her work that she has handled all the conferences and held all the posts very nicely and gracefully. She was the founder secretary of our ISOPARB in Prayagraj, and currently she is a secretary of Menopause Society in our Allahabad, and she's a very nice practitioner also. Then we have Dr. Veena Gupta. She is another senior faculty member of MLN Medical College. And apart from that, she has medical legal, she has a degree for like PG diploma in medical legal science from Symbiosis. That is an additional feather to her personality. And she has like many research papers in national and international journals have been published, and she has served AOGS for more than 10 years. Now, I'll hand over the things to Dr. Amita to introduce Dr. Prabhu, and we are keen to listen about the exosomes therapy.
Thank you,
By
Manisha Dee,
Dr.
for
Prabhu.
kind. Thank you, Manisha Dee, for very kind introduction. And congratulations and thank you, Dr. Ragini Dee, for such a wonderful talk. We all thoroughly enjoyed your talk. And moving towards the next scientific session, that is on exosomes. Nimisha, please. While I was reading his CV, it was very impressive CV. He's MSc in molecular medicine and stem cell technology, PhD researchers in biotechnology, postgraduate diploma in chemoinformatics, trained in drug discovery, cancer biology on Johns Hopkins, advanced stem cell biology from Pasteur Institute, France, and postgraduate diploma in management. Dr. Prabhu Mishra is a stem cell biologist with a vast experience in autologous bone marrow concentrate in premature ovarian failure, various application in platelet-rich plasma, mesenchymal stem cells, induced pluripotent stem cells, chimeric antigen T-cell engineering, nanomedicine, and genome editing tools. Further, he has worked extensively in the fields of epigenetics, molecular medicine, and various molecular biological techniques. He has superheaded studies showing immense benefit of cell-based therapy in the field of infertility, especially for the women with poor ovarian reserve, refractory thin endometrium, Asherman syndrome, and regenerative gynecology. All the areas where we gynecologists and obstetricians are very perplexed. He has many research papers, textbooks, and patents to his credit. His passionate teachers, thousands of trainees spread across the globe. He is the founder, president of International Association of Stem Cell and Regenerative Medicine, and CEO of STEM Max Research and Therapeutic Private Limited. So he's going to speak on extracellular vesicles, usually exosomes. He's going to enlighten us about this wonderful molecule of hope that can be applicable on various diagnostic and therapeutic things in obstetrics and gynecology. Now the stage is all yours, Dr. Prabhu. Please enlighten us about exosomes therapy.
Thank you so much, Dr. Amita, for introducing me. And first of all, I'd like to thank Dr. Bandha ma'am for inviting me and all respected doctors here. Dr. Agni ma'am, then Dr. Ranjana Khanna, Dr. Chitra, everyone. It's my best regard to all of you. So I'm going to give you the overview about like how we moved from, starting from the platelet-rich plasma, then bone marrow stem cells, adipose stem cells, heard about the like macrofat, microfat, nanofat grafting, SVF. Now we are moving towards the nanomedicine of the exosomes. So these all orders and some of the indications we will cover like thin endometrium, Asherman syndrome, premature ovarian failure, and the POI. And then recently we have got the approval for this. We have started the clinical studies of endometriosis with the exosomes and the SVF, intraperitoneal, intralesional injections, and some aesthetic gynecology indication like GSM, vaginal atrophy, SUI. These all we are going to cover, like what to do, where to do, and which biologics to choose. So let me share my presentation. Just a second. One minute, share. Yeah. Yeah. So my slides is visible to everyone, right?
No, we can't see your slides.
No.
No.
Just a second. 1 second, ma'am. One second, ma'am. I'm just I'm resharing again. Now it's visible to everyone?
No,
No,
we can't see the slides.
we can't see.
Wait. There again. Now?
Yeah.
Yes, now we can, now it's okay. Now it's visible.
Make it full screen now.
Yeah, I did full screen, ma'am, now.
Okay.
So, starting from the all basic biologics in regenerative medicine, I always talk about, like, before starting, like these all biologics when we talk, starting from the PRP, stem cells, everything. Why the separate branch needed, the regenerative medicine? Sometimes we always confuse, like, oh, stem cells equivalent to regenerative medicine, equivalent to PRP, all perinatal biologics. Why the need? There is IVF is well established. We are doing the pickup second day or third day. We can have the embryonic stem cells from discarded embryo and all. Transfusion medicine is well-established branch where we do all component depletions, all plasma, peripheral blood, we are playing there. Medical oncology, hemat is already well established. We can do the hematopoietic stem cells as we are doing bone marrow transplant for hematology for last 4 decades. So we can do all those. So why the separate branch needed as a regenerative medicine and what it covers? So idea behind that to have the separate branch, because if we are having the good car,
Kindly make it full screen, sir.
ma'am, it's a full
The
screen.
slides are not visible full screen.
It's a full screen. It's a 16 by 4. It's a full screen. It's a full screen.
Not visible.
We can't see as full screen. To us, it is not visible as a full screen. Now it is better.
Yeah, it's,
Now it is.
Yeah,
Still
yeah.
better.
it's better.
Now it's better, sir. Now it's
Now?
Not now.
No, not now.
not
Initially
exactly,
it was
sir.
better.
Yeah. Now.
Yeah.
Now it's
Now.
Okay. Because when I was doing this play, it's going to 100% and now it's a full screen or it's not?
no, not now. Yes,
Okay.
Now it's fine.
This fine.
Yeah.
This is fine.
it's okay.
Okay, not so good, but it's fine. It is becoming smaller.
Yeah,
Yeah, now.
it was better previously, na?
Yeah,
No.
now it's fine.
Okay.
Now it's better.
Yeah, now it's good.
Now it's fine. Let it be.
Yes.
So starting from this, so like I was telling you, like if we are having the good car, we need the good road to enjoy the maximum efficacy. So regenerative medicine is the area. One is the stem cells. What you are doing into the clinic, except hematology, all are cellular therapy, cell-based therapy. As per the regulatory, it's only 2-3 things are permissible, like autologous, minimal manipulation. That is, you cannot culture, cannot expand, cannot add any enzyme or chemical to modify the cells. And same setting surgery, that is, you cannot transport the cells from one facility to other facility. This is in between of doctor and their patients through informed consent. So that's a part of the cell-based therapy, cellular therapy. Then another area came energy-based devices, like all your laser, radio frequency, HIFU, HIFEM, etc. Those which are bringing the functional and changes at the cellular level. And another is all regenerative compounds like GCSF, GMCSF, etc. So, and then another is scaffold, tissue engineered products, cellular matrix, etc. And nowadays recently added this nanoparticles, like most of the indication where the cell doses, like paracetamol, we need to take 500 milligram to 1 gram. Similarly, stem cells have certain dose, like, so PRP have certain dose. If 5 ml, how much dosage is required? How many injections are required? If route of administration, like neurological indication, neurodegenerative conditions, if we are doing lumbar puncture, intrathecal injection, so in 2 ml, we need around 48 million of the cells. So cell volume versus cell doses, this challenge came. So another area they have added, the nanomedicine, where the exosomes, liposomes, secretomes recently have been added. So coming to the definition part of these all biologics, stem cells definitely have the property of self-renew, differentiate into the targeted cells, and then the plasticity. Ask anyone what is the stem cells. They will tell you all totipotent, pluripotent, multipotent, everything. So ideally, stem cells, if you'll see here, totipotent is only 2 to 5 days of embryo, which are part of the research. Embryonic stem cells is a pluripotent stem cell, which are 2 weeks to 16 weeks. After that, all are adult stem cells. All are multipotent stem cells. What we are doing into the clinics, all are multipotent. None of them are totipotent or the pluripotent. Then another fancy terminology these days, hematopoietic stem cells, mesenchymal stem cells. Any blood source giving you hematopoietic stem cells, any tissue source giving you mesenchymal stem cells. Hematopoietic stem cells, if your goal is neovascularization, neoangiogenesis, go for the either peripheral blood or the bone marrow. If your goal is immunomodulation, anti-apoptotic, anti-fibrotic, immunomodulation, that is an autoimmune conditions, go for the tissue source, adipose tissue, fat grafting, nanofat, SBF, mesenchymal stem cells for autoimmune conditions. Like similarly, like in endometriosis, you cannot do the peripheral blood or the bone marrow. It will aggravate. In case of thin endometrium measurement or the premature ovarian failure, always and always either peripheral blood or the bone marrow, never ever go for the adipose. So this is the way you can select the biologics. Another question I will answer here, should you go for the cord blood banking or not? Or is this too late now? So ideally, cord blood banking is like in the era of iOS 17 or 18, we are living with iOS 3. So it's nothing bad, nothing good. It's like, the biggest challenge of the cord blood is we are cryopreserving 25 to 40 ml. In that, hardly it giving you 30 to 40 million of the cells. For any transplant, a stem cell transplant, the cell dose required is 2.6 into 10 to the power 6 total nucleated cells per kg of body weight. So if patient weight is 50 kg, we need 140, 150 million of the cells. That cord blood samples never ever will give you. This is the biggest challenge with the cord blood scenario. So cord blood bank is we cannot say it's a bad or good, but it's definitely obsolete as with the scientific advantages. In the gynecological indication, if you'll see here, in this recent era, what was the development? If you'll see all biologics coming to the starting from the PRP, platelet-rich plasma. Inside the plasma, the platelet concentration is more than double, triple, that is increase the hematocrit level. That's a platelet-rich plasma. In the plasma sample, platelet concentration from the baseline more than double, triple, 10 times, 8 times is the platelet-rich plasma. There is a various types, high leukocyte, low leukocyte. In your all gynecological samples, we need the high leukocyte because we need the more neoangiogenesis. Another is bone marrow aspirated concentrate. BMAC, bone marrow, majorly we are using for Asherman syndrome or the recurrent implant failure or the premature ovarian failure. Now, in this, where to choose PRP, where to choose bone marrow stem cell, especially when in the thin endometrium or the recurrent implant failure. In plain thin endometrium coming first time, less than 7 mm thickness, poor vascularity, you can go with the PRP. But if there is a recurrent implant failure, you should always and always go for the bone marrow because, and if it's a recurrent implant failure, always and always do the CRP, C-reactive protein, and serum natural killer cells. It's always high. In that case, you cannot do the FET cycles. You need to manage with the low corticosteroids in the previous cycle. Then you can either go for the PRP, and even before doing the PRP, 48 hours before, do the GCSF subcutaneous 1 ml 300 mcg and vitamin D3 to down-regulate the inflammation, Th1 group of the cells, interleukin 2, 10, etc. So vitamin D3 6 lakh unit intramuscular 48 hours before, then you can go for the PRP or bone marrow subendometrial by the histoscope. So this is the way you can choose for this. Then adipose SVF is another biologics, macrofat, microfat, nanofat, wherever you need the volumizing effect, like labia majora augmentation to G-spot amplification to wherever you need the volume, and even in SUI, stress urinary incontinence, we are giving nanofat, paraurethral, suburethral injections and into the mid urethra and towards the anterior rugae. I'll show you some of the slides. And once we are preparing the nanofat, centrifuge it, and that centrifuge nanofat, SVF, stromal vascular fraction, we are using for endometriosis, intralesional and intraperitoneal during the surgery. So this is the way adipose you can go for the endometriosis. Mesenchymal stem cells these days used, it's in our country, it's a part of the clinical trial, but many of the country like Dubai and all, the mesenchymal adipose culture is permissible. People are using for IV injections for anti-aging and the longevity effect. Amniotic fluid you can use for various things. Once you are planning the C-section, you have given the incision. Before rupturing the amniotic membrane, you can take the 20 cc of the amniotic fluid, mix with the 20 ml of the normal saline, 1:1 ratio, centrifuge at 3200 RPM, 12 minutes. And then meanwhile, you are taking baby out, and alongside the incision, alongside the suture, you can give intradermal, subdermal injection to prevention of the keloid formation. And same you can inject inside the intradermal, subdermal into the stria and the stretch mark. So amniotic fluid, and then apart from that, we are also giving them a spray on that for 7 days. They can keep it into the fridge at 2 to 6 degrees Celsius for 7 days, and they can use as a spray. So you will not see even a stretch mark formation in that case. Placentrex we all have been using for decades and decades. And nowadays then exosome. Exosome is a nanoparticle. I'll talk in later of the slides. It works like a both way, diagnostic material as well as the therapeutic material. Ideally, exosome, if you'll see in a layman, if I'll talk about what exactly. So it's exo means external, soma means cells. It's a cell-free substance. So ideally, it can be prepared by ultracentrifugation, ultrasedimentations, or by different culture method, definitely. So for minimally manipulated, you can go for the ultracentrifugation or photothermal biostimulation. So we can give the far infrared light. So once we prepare the high leukocyte PRP, put the tube inside the 40 degrees Celsius heat block we all are having in IVF facility and keep inside the laminar flow for 12 minutes. And then there is a definitely a specific device comes, Metasol technology and all. There are various devices for the preparation of the exosomes. So ideally, these devices are doing the photothermal biostimulation at certain temperatures and the certain kind of light they breaks down into the nanoparticle. So scientifically, it's 20 times better than the PRP. So they break down into the nanoparticle, so their penetration are very high. So even in cell a smaller volume, you are giving the maximum number of cells. This is the superiority of the biologics, because now next generations are coming in regenerative therapeutic. So exosome maybe or will replace the PRP in a superior way in coming few years. Then definitely autologous, allogenic is only permissible is the BMT, rest always autologous. In our country, DCGI gives the law, and the ICMR gives the guideline. And these are the current indication. We can see the advantage into the gynecology, starting from the thin endometrium, POI, Asherman syndrome, endometriosis, then the postmenopausal indications and perimenopause, urinary incontinence, interstitial cystitis, overactive bladder, lichen sclerosus, female sexual dysfunction or vulvovaginal rejuvenation, etc. So these all protocol I'm going to share with you. This is the regulatory scenario given by the Parliamentary Gazette. It's published in 2018 about the stem cells and regenerative medicine. So point number 2 is only permissible through informed consent in between of doctor and patients. Rest all are part of the drug. They all are more than minimal manipulation. So what we can do, isolation of tissue, washing, centrifugation, suspension in acceptable medium, blah, blah, blah. So ideally, we cannot culture, cannot expand, cannot add any enzyme or chemical to modify the cells. So this is what currently in between of doctor and patients through informed consents, we can do that. Apart from that, all are part of the clinical trial. Now coming to the adipose stem cells. Because adipose is one of the great source of exosomes, and it's very simple and it's widely practiced. I'll come with each individual, then I'll talk about 2-3 slides about the PRP, bone marrow, and then exosomes definitions and all, and some clinical indication. Doing the lipoaspiration 30 to 40 ml of the fat taken from either from the flank, either from the thigh, either from the like wherever the approachable sites. Ideal site, as lower you go, you are getting the better adipocytes. So medial knee is one of the preferred area. 30 to 40 ml of the around fat. Then keeping that fat into the vertical position, like just to remove all tumescent fluid and lidocaine and all. Lidocaine bicarbonate is it's called a tumescent fluid. So all and red cells and all, and then homogenizing with the different filter. 3.2 microns for 30 times, connect with the FEM to FEM connector. Then again with the 2.4 microns, 1.2 microns, breaking down into the nanofat. And that nanofat, we centrifuge it, and that centrifuged nanofat is giving you SVF, stromal vascular fractions. And in bottom, there is a soup, that's a juice. That juice is a cocktail of all growth factors, cytokines, chemokines called SVF, stromal vascular fractions, which contains secretomes, exosomes, T regulatory cells. This is what you can use as a minimally manipulated. If you want a pure populations, then you need a culture facility and all, but culture will be the part of the clinical trial only till centrifugation is permissible in between of doctor and patient. So once we got the lipoaspirate, use the tip cap, keep into the vertical position. Top part will be the oil. This is the RBCs and tumescent fluid. Mid part will be the fat. Then connecting with the FEM to FEM connector with different filters, homogenizing it, and then we are centrifuging it. Here the various steps you can see. This is the tumescent fluid. So like Here oil and the fat mid part, and then this is the tumescent fluid, then fem to fem connector, and this fem to fem connector is the homogenizing and centrifuging, and then the pellet comes. That's your ideally stromal vascular fractions, which are cocktail of secretomes, exosomes, and all. Here in SUI, we are using as well. So in FUI, you can do that. We call it secretomes. So this microfragmented adipose tissue and secretomes inject transurethral via cystoscope under local anesthesia. Injections are placed directly under mucosa, 1.7 centimeter distal from the urethral neck, like a bulky agent. At 3 and 9 o'clock, injected volume you can do around 4 to 5 milliliter. Two additional concomitant after that, once you injected, you can inject the high leukocyte PRP around 1.5 millimeter distally to bring that nanofat you have injected in contact with the urethral musculature. Patient can be followed 3, 6, 12 and 3, 6 and 12 months, and then all like TVS, cuff test, 24-hour pad test you can do. If you don't want to do the cystoscope, simply you can go towards the anterior rugae, mid-urethra you can go around 1.5 ml, both of the sides, paraurethral, you can do that. And all along the vaginal wall, 0.2, 0.2, 0.2, you can do if it's a SUI, GSM, if you want to address. And if you want to address the lubrications as well as the female sexual dysfunction, you can go both towards the clitoral base, in the bottom of the clitoris, both of the side, 0.5 ml, 0.5 ml, as well as to the skin gland, 0.5 ml, 0.5 ml, and then the paraurethral, suburethral, and towards the anterior rugae, anterior wall, you can inject this. Coming to the exosomes, as a definitely any body fluid are giving you the exosomes. CD markers, how to characterize it, how to prove it. It is the exosome CD63, microRNA 13, 21. There are many one, but CD63 is the gold standard to characterize. You can do that. It contains exosomes. Widely taken is the peripheral blood. Second is the fat. Third will be the wheat and jelly. These three are the popular source for the exosomes. It works like a diagnostic material. Many of the reputed institutions in our country now started using and doing the clinical trial, because even, you know, one of our group is working on the type 1 diabetes, you working like a diagnostic material with the exosomes. So through the endoscopy, they are encapsulating exosomes from the peripheral blood, injecting back near the pancreatic tail. In 24 hours, they are checking how much insulin they are releasing it. On the basis of that, you can encapsulate stem cells and you can just give the transabdominal, you can release that, or with the endoscope, you can release that. And then after that, it gives you the like a sustained release of self-renewing. And this changes into the C-peptide, changes into HOMA-IR, changes into HbA1c, we have observed in this kind of indications. Then apart from that, exosomes, wherever you are doing PRP, you can slowly replace with the exosomes. If you are shifting towards that, it's a 10x better than the PRP, definitely, because their penetration are very high. These are the protocols, manual preparations. You can do that if you are doing the manual with the ultracentrifugations methods. These are the various steps. But ideally, the idea behind that, there is a blood source, is the EG source. Prepare the high leukocyte PRP. Then there is a specific machines to convert them into exosomes. And this is what you can use. Allogenic, these all plants learned these days in our country, it's not permissible. These are some of the advances, like these are the indication people are trying exosomes. Alzheimer, glioblastoma, these are the clinical trial report in our country currently. Glioblastoma, neurodegenerative conditions like multiple sclerosis and all. Then osteoarthritis people have tried. So various source, even in one of the group in Bombay, they have used the human menstrual fluid by the ultracentrifugation separation of the exosome for the ALS, amyotrophic lateral sclerosis, and they are giving the intrathecal injection into that. So this kind of that, but it's not concluded how much efficacy is there. Then in aesthetics, because the non-healing ulcer, diabetic food, because once you are going to the targeted or specific organs, then there is a very good deal, like in ulcerative colitis, Crohn's disease, IBS, IBD. Like when you are giving to a specific organ, because targeting to the specific, like there is no paracrine signaling, you are not dependent, like you are giving IV, 70% goes to the lung and only 30% reaching to the targeted cells. Here you are just going to the targeted cells. In that case, their penetration are very high. That's why it giving you the anti-aging effect as well. And how it works, so it increase the number of extracellular vesicles or exosomes released during senescence of fibroblast, epithelial cells, and cancer cells. a decrease in the level of circulating extracellular vesicles with age, at least from 30 to 60 in humans. Changes of extracellular vesicles or exosome compositions like microRNA, proteins, lipid associated with aging or senescence. So that's why you need the boosting of that, and this boosting can be done ex vivo. Once we need that sample particularly, convert them into the exosomes and inject it back to activate the cells. Then definitely the intradermal, subdermal injections or into the periphery of the wound you can do. You can just make the high leukocyte PRP, convert them into the photothermal biostimulated exosomes. And once it's a diabetic wound, all along the wound, intradermal, peridermal, and then you can use as a PRF gel, platelet-rich fibrin gel. So gel, what the platelet-rich fibrin does, it gives you the cellular matrix, it giving you the network. So it traps the cells and keep it intact at a certain place. So how to retain the fibrin? Don't add any anticoagulant. Just take the peripheral blood, 20 to 30 ml. Don't add any anticoagulant. Centrifuge at 700 RPM, 12 minutes. Keep into the fridge for 6 minutes, 7 minutes. And that fibrin gel you can use like a dressing material of non-healing ulcer or diabetic foot or critical limb ischemia or any peripheral vascular disease. In that case, the only thing you need to take care once you are dealing with a non-healing ulcer or diabetic wound or any wound or C-section or any active wound, in that definitely do the culture because it's a food for them. So because sometimes if any bacterial growth will happen, so because this is the food for them, it's a chemokines, cytokines, growth factor to them. So always do the culture test before doing the PRP or the exosomes or the stem cells. And top of that, always a hydrogen peroxide cleaning and all. And every dressings you can use this platelet-rich fibrin and the high leukocyte PRP or the exosomes into that. Then another is in androgenic alopecia or the alopecia areata. So especially because it's better than PRP because their penetration are very deep. Here, people these days, most of the plastic surgeons are combining exosome along with the FUE, follicular unit engraftment or the follicular unit transplant, or those who don't want to go for that or having the better. In that case, what it does, it activates the dermal papillary cells or the bulbar cells. So in that case, you are just giving the Napas technique, intradermal, subdermal, all along the scalp. And you can just prepare the high leukocyte PRP, do the photothermal biostimulation, convert them into the nanoparticle, and you can activate that. Or like sometimes people are also doing with the especially in the thinning of the hair and all. So due to the endocrine disturbance, in that case you can do with the micro needling as well. Then fine line, front line, nasolabial folds, skin rejuvenations. You can just prepare the high leukocyte PRP, convert them into the nano particles, and you can give like micro needling or dermapen, or with the insulin syringe, you can do the like all along the fine line, front line, nasolabial folds, infraorbital space, and the crow's feet, etc. So that is it gives you the tightening effect as well as it giving you the rejuvenation effect or revitalization effect into that cases. And then the various other biologics like adipose stem cells, if you are having the lab or the culture facility, you can also do the specific like for chondrocytes, myocytes, then many other indication opens the door. So basically, in that case, how it works, these all exosomes. So inducing regeneration of epidermal skin barrier by increasing synthesis of ceramides, dihydroceramides, and sphingosine, reducing inflammation through downregulation of multiple cytokine levels, reducing the level of pruritus causing cytokine, inducing synthesis of collagen and elastin in fibroblast, inducing proliferation of fibroblast and dermal papillary cells. These are some of the paper initially I have published. There are very comparison for SUI and other adipose stem cells based exosomes and all. These are my paper on the PRP. You can find out it's like more than 2,700 citation for this paper. This was a comparative study of the thin endometrium and ovarian rejuvenation with Dr. Manjula Angani, published in 2017 and 2021, 385 cases, which biologics, what should be the route of administration, etc. Now, just give you some of the overview about the PRP based, because most of the time, because exosomes you are preparing from the peripheral blood. So first you are making the high leukocyte PRP. That protocol should be, people say, most of the kit people, they know, oh, I am using this kit, that kit. I'm using butterfly needle, I'm using vacutainer. See, this is the all megakaryocytes. Megakaryocytes is 2 micron. So there is nothing like you need to use the butterfly or the vacutainer. Whatever comfortable to you and your patients, this needle you can use. Why PRP is having the clinical uses? Because it exhibits the angiogenesis and the inflammatory property. It proliferates the cells. It's showing the chemotactic movement, differentiate into the targeted cells. Definitely it immunomodulatory and antifibrotic activities. And then people ask, oh, we activate the PRP, we do this, we add anhydrous calcium chloride, we do the thrombin activation. Why to activate that? Activation is required only for osteoarthritis. Apart from that, none of your indication required activation of PRP, especially in gynae. So activation means you are reducing, shortening the time of release of the growth factors on the targeted cells. So ideally, once you prepare the PRP, you should use within 18 minutes. After that, it's just a lubricating agent. It's just a plasma, it's a protein, it's a peptide. This is going to precipitate. So once you prepare, use within 18 minutes. Then another question, what should be the ideal time interval between the two injections? So ideal time interval in most of the indication between that, it's a 4 to 6 week. 7 to 10 days is the inflammatory phase. 10 to 30 days is the proliferative phase. After that, all are tissue remodeling phase. So maximum effect of PRP lasts for 6 to 7 months, 8 months, and ideal time interval between the two injection is 4 to 6 weeks. Some of the exceptions here in androgenic alopecia, you can prolong the inflammatory phase. As well as non-healing ulcer, you can prolong the inflammatory phase. Then people talk about high leukocyte, low leukocyte, fibrin base. I already told you, like, low leukocyte is only for osteoarthritis. In gynae and aesthetics, you should always go for the double step centrifugation. Here is my protocol. Always take 30 to 40 cc of the peripheral blood. Never ever use EDTA as an anticoagulants. They are chelating agent. Always go for sodium citrate, ACDA, or the heparin. Heparin, if you are using, use the 5000 international unit, 1:10 ratio. If you are using 40 cc of the blood, go for the 4 ml of the heparin, 5000 international unit. First step centrifugation is 1800 RPM. This is the low leukocyte. Take entire plasma. Second step is without anticoagulant. Recentrifuge 3200 RPM, 6 minutes. And this is the from the bottom you are using that. That's your platelet rich plasma. Here is the explanatory view. This is my trademark name, OSHEL. So we are taking around 30 to 40 ml. Blood is around 1800 RPM for 12 minutes, 3000 for 6 minutes. If you are using for subendometrial injection in thin endometrium or SRMan, 6 to 8 ml your injected volume, like anterior wall towards the fundus, both side lateral, and wherever you find the green grass. In ovary, PRP doesn't do anything with the AMH. We have not seen any changes. But AFSH, if 80, 90, 100, it comes down to 20, 30. That's why we always prefer in ovary, never do the PRP, always go for the stem cells. We have not seen any miraculous results with PRP in case of the ovarian rejuvenation or especially for the POF. If you go with the Bologna criteria, like age group for less than 40, MH, FC, etc. So if we talk about that, categorize very clearly. You are dealing with the fertility, premature ovarian failure, direct go for the bone marrow stem cells. If you are dealing with the perimenopause, low MH, POI, managing menopausal symptoms, or pluses, etc., then you can have the transvaginal PRP, it's okay. But if you are dealing with the fertility, a streak ovary, Turner kind of things, laparoscopic injections, bone marrow stem cells, ideally it should be a gold standard in that case. Then coming to the some of the indications about wherever you are doing the PRP, you can replace with the PRP based exosomes. Here, if we talk about the O shot, is a very popular terminology given by the Charles Runels. So in female sexual dysfunction, like we are always using the BLT cream. It's a topical anesthetic cream, 23% lidocaine, 3.5% tetracaine. Applied towards the anterior vaginal wall, around the urethra and over clitoris before PRP injections. People ask how much volume, so 4 to 5 ml, high leukocyte PRP. Suburethral injections, you can give 1 cc, a skin gland both sides, 0.5 or 1 cc each or 0.5 cc each, and clitoris bilateral each side. Don't go like a 90-degree from the top, go from the base like alongside the corpora cavernosa, and then use 1 ml syringe, 27 to 31 gauge of the needle, 2 treatment sessions 1 month apart. Then people talk, oh, can we combine with the laser, RF, etc. In same setting? No, because any laser or RF is giving the heat of more than 45 degrees Celsius, and none of the growth factors survive after 21 degrees Celsius. So either there is a two protocol. What you can do the laser or the RF first. After 7 days, you do the PRP. So you are prolonging the inflammatory phase. But in inflammatory phase, again, no intercourse then. So this is the protocol you can follow for the female sexual dysfunction in that case. Then SUI also you can can do the exosomes or the PRP. So 27 to 31 gauge needle injected into the anterior vaginal mucosa around mid-urethra, which is approximately 1 centimeter below the urethral meatus. With the depth, people always do the mistakes. They go only 2 to 3 mm. No, always go very deep, around 15 mm. 2 ml is injected underneath in the mid-urethra and 1.5 ml for each side of urethra. No anesthesia is needed in this procedure, but if possible, you can give. Repeat 3 times in a month apart. Yes, case C-section scar, I already talked about the amniotic fluid. You can replace if you are not doing the amniotic fluid. You can do with the PRP all along all alongside the C-section, whatever the incision you have given, and to the stria stretch marks. Vulvar dystrophy. Injected here, PRP are injecting into the fan technique, punctual or retrograde administration. Patients are receiving 3 PRP for 4 to 6 weeks apart, and you are injecting, especially like if you'll see here, like retrograde techniques, if you are give like a retrograde linear thread. This would be your approach. Then vaginal rejuvenation, dryness, GSM symptoms. Here you are injecting like into the vaginal mucosa. So using the speculum or inserted into the vagina using the mesotherapy. Mesotherapy is you can combine with the vitamin C. You can combine with the hyaluronic acid. This you can combine. So you need the neocollagenesis here as well. So non-cross-link hyaluronic acid you can combine with the PRP here, or the vitamin C around 2 grams or the 5 grams. You can combine in that case with the mesotherapy techniques here. So 5 ml are injected into the anterior and posterior wall of the vagina. PRP is administrating of the papules of 0.1 cc volume with 1.5 centimeter of the interval. Then another is dysuria, recurrent urinary infection. You can do like suburethral injections and posterior and anterior wall of the vagina. This right now we have not published, but we have done many cases with Dr. Nikita Trehan and Dr. Hafiz Rahman. Around more than 40 cases till now we have did, and we got the amazing results with that. Then another is genital fistula. Dr. Hafiz have tried. So PRP and PRF here we are injecting around the fistula into the tissue, and PRF gel also, pyrrolate fibrin, was interposition into the tract. So like really like most of the time when PRP is accompanied by flap or interposition of the buccal mucosa, sometime we give. And the genital prolapse like in the operated site where the mesh implantation you do. And then the episiotomy scar. So again, here is like a Napas technique, like transdermal injections at multiple superficial injection into the papillary dermis. Sometimes you can also give the deep injections by point under the scar. If the scar is drawn, it is worth cutting with the needle beforehand. So definitely like these kind of indications have taken a leap in last 2 decades. But definitely it's not a magic medicine. Even being a population of 1.4 billion, we are lacking the strong registered clinical trial, not a large study, very small number of study we are having, an individualized. So multi-centric studies is required to have some conclusive opinion about that. Some of the books I have written in regenerative medicine, in infertility, then another on aesthetic functional gynecology, one on the anti-aging longevity hacks. These are some of the fellowship I run. And every year I do this conference called Longevity Revolution. Next year will be in May in New Delhi, 22nd to 24th. This is my Instagram. So thank you. Thank you so much, ma'am, for this opportunity. Thank you.
Thank you, Dr.
Thank you, Dr. Prabhu, for such an enlightening talk on such a novel and revolutionary concept of exosomes therapy in gynecology. I would like to congratulate the team ISOPARB for choosing such a wonderful topic, because we don't know anything about this and this concept was very new for us. But Dr. Prabhu has made us understand what is exosome therapy and where we can use it in the gynecology. These exosomes are the extracellular vesicles which are secreted by almost all types of cells, and they encapsulate the biological markers from the cells of origin. These mesenchymal cells can be obtained from the bone marrow, adipose tissue, umbilical cord, endometrial cells, and also from the amniotic fluid and placental tissue. The mechanisms of regenerative, antifibrotic, immunomodulation, and anti-apoptotic. Because of these properties of these exosomal cells, we have its use in gynecology, like in infertility, endometrial repair, ovarian regeneration, then endometriosis and cancer management. In obstetrics, the placental exosomes can be used in RPL and pre-eclampsia. Sir, you have beautifully explained the topic, and I think most of us have understood the concept of exosomes. Now, at last, I would like to thank the team of ISOPARB for giving me the opportunity to chair a session which was on a very recent and interesting topic and by a very learned speaker, Dr. Prabhu. Thank you so much. Thank you all.
Thank you.
Sir, may I know what is the cost of this therapy?
That's
and
very
where we can get it done?
30,000 to 1.5 lakhs or 15 lakhs, sorry.
15 lakhs.
No, ma'am, see.
But like other therapies, it has its own limitations
Ma'am,
also.
I'll tell you one thing.
Cost hai, then
that depends which therapy you are taking.
Your preparation
because long-term effects abhi study nahi hue na.
Your preparation, your preparation cost is 6 to 7,000. After that, it's your appetite.
How much, sir? How much?
6 to 7,000 rupees is your preparation cost.
And how many sittings you need?
For what?
Like in hair
For
and
which
skin,
condition are you talking? In which condition are you talking?
Dr. Veena, we are using exosome, which is no, we don't make. There's a बना बनाया एक्सोसोम भी आता है, वो थोड़ा सा महंगा पड़ता है, लेकिन इससे आसान होता है कि दे सकते हैं. तो जो डॉक्टर प्रभु कह रहे हैं ना कि फिर टीका कितने का लगाना है, वो आपका काम है.
Exactly.
अब अगर प्रभु जैसे लगाएंगे तो वो टीका 1 लाख का भी लगा सकते हैं, हमारे जैसे लगाएंगे तो 10-15 हजार में चुपचाप हट जाएंगे.
मैम डिपेंड करता है सेंटर का. अब देखिए मैं रेंट दे रहा हूँ 10 लाख रुपया, तो अब वहां पे उस हिसाब से रेट है.
मैं वही बता रही हूँ ना, टीके का कोई रेट नहीं है. आपने सामान तो इतने बनाया, उसके बाद टीका आपके हिसाब से लग जाता है.
योर प्रिपरेशन कॉस्ट इज हार्डली 7,000.
We can get the टीका ना.
मैक्सिमम 10,000 भी आ जाता है किसी अगर ये हम लोग जो बाहर से लेते हैं ना.
हाँ 10,000 तक आता है, मतलब 7 से 10,000 इज योर कॉस्ट. आफ्टर दैट मैम रेट कुछ भी इसका यूनिफॉर्म नहीं है अपने देश में आज के डेट में.
नहीं तो किसी चीज का क्या है, सिजेरियन का भी रेट नहीं यूनिफॉर्म है, डिलीवरी का रेट भी नहीं यूनिफॉर्म है. CGHS में आप 13,000 विद डिलीवरी विद मेडिसिन कराते हो, और अगर उसमें कराते हो क्या नाम है रोज वॉक में, तो 4.5 लाख में कराते हो. उसकी क्या बात है.
एग्जैक्टली बिल्कुल. इसका कोई साइड इफेक्ट डॉक्टर प्रभु?
वही तो
मैम इट्स ऑटोलोगस, सो डेफिनेटली इट्स नॉट साइड इफेक्ट. फिर भी कभी लोगों को फीवर आते हैं और नौसिया होती है 30 मिनट्स के लिए.
वीना दीदी उसका एक बहुत अच्छा आंसर और
व्हाट इज द रोल इन
इफेक्ट होगा कि नहीं होगा ये नहीं मालूम है. डिस इफेक्ट कोई नहीं होगा.
व्हाट इज द डोज इन रिजुनोवेशन डॉक्टर प्रभु?
Ma'am, say dose like around 230 million. Like if we are taking around for IV, if we are giving, we need around 70 to 80 ml of the peripheral blood. Then we will get the good count.
70 to 80 ml.
So we can have only one sitting, na? Or you need more?
One sitting, ma'am, with some definitely cocktail of some nutraceuticals and all. So post that you can have some N-acetylcysteine, L-carnitine, and some cocktail magnesium.
Yeah. But I am not very convinced about its role in cesarean, because we've been doing cesarean since times immemorial and not using all this. So, I mean, what is the point, and in which exact indication are you suggesting that we take the fluid and then we, mix it with the saline and then we inject? We are getting such beautiful results like that only. So why the hell would we go in for anything else and spend a little more time doing the surgery?
Straya ke liye basically.
Cesarean ke liye he was saying.
Cesarean ke liye hypertrophic scar में क्या
hypertrophic scar के लिए ना, जैसे आपने मैंने कहा.
अच्छा keloid के लिए.
Keloid formation से stop करते.
That's what I'm saying. Hypertrophic scar या keloid में.
Yes, some patients.
Tell me one thing about the genital fistula. What is the timeline when you should start the therapy?
Timeline, ma'am, see, for result you can see after 2 to 3 weeks.
No, to start after 6 weeks, after 6 months, after 1 year.
In that case,
when should it be started? Because if you do it later, I think you can explain me better.
Ma'am, see,
it should start as early as possible.
My core experience with the thin endometrium and the POF, POI, and endometriosis. These all indications like genital fistulae, and these all done by Dr. Hafiz. So like most of the time we don't do. But he said, Prabhu, let's try in these cases. So we did the fibrin and all. Very few number of cases.
Okay. It's under trial only. Under trial only.
Under trial. It's not like we can say, we can claim like this is going to do something.
And in the case of low AMH, does it actually work? in ovaries.
Ma'am, that's why I told you PRP doesn't work in that case. FSH, you will see the changes. FSH 70, 80 हैं, 20 तक, 25, 30 आ जाते हैं. But the thing is, if you'll see that, but POI cases, it's okay. You can do the GCS.
Follicles and the quality of the follicles,
Quality, it
will
improves.
it improve?
If you are giving the bone marrow stem cells into the cortex, definitely it gives you the quality. We have
It improves the quality and the quantity.
quantity as well, ma'am. That's why now I told you, like PRP is the biologics for endometrium, bone marrow stem cells is the biologics for the ovary. PRP doesn't work in the ovary.
Dr. Prabhu,
So
what
the
about-
exosomes.
सर RPL में कैसे यूज कर सकते हैं रिकरेंट प्रेगनेंसी लॉस में?
Like same way like you are doing for endometrium, ma'am. It's the same way subendometrial injections you can do.
Just for endometrium.
Just for endometrium in that case. And
If endometrium is the reason, then only it will work. In RPL, if endometrium is the reason for RPL,
but it's good that for once and for all, you have cleared that there is no rule of there's no rule of cord blood banking. That is one thing.
This is what I was going to ask. What about cord blood preservation in previous scenario?
He has told us, he has said that the amount of stem cells that you get actually out of it are very less, and you need more. So it is practically useless.
Ma'am, even the cord blood banking, when it came in 1997, the idea behind that, if first child having the thalassemia, sickle cell, or any kind of hematopoietic conditions, so if they are having the donor, and like haploidentical 50% HLA match or not match unrelated donor we do. In that case, top-up dose required to prevent from the GVHD, graft versus host disease. This was the ideal goal to start the cord blood banking. But the all private players have taken in a very
But now they take it from the iliac crest.
Yeah, the iliac crest is
So
again
long, 1972 से ले
bone marrow, yeah.
So
They are
yes,
taking
bone
it
marrow.
from there also, na? Jaise, in case there is some disease in one being brother or sister, then the other sibling, they take from the...
That's a BMT, ma'am. That's we are doing.
That is BMT.
Yeah, that's a
That
BMT.
is not cord blood banking, na?
No, that is BMT.
That's a BMT.
And nowadays, na, many companies, अभी तो बहुत कम हो गया ना उनका. I think they have also understood that it's not
now
working.
they are not
and
coming.
now people are aware now. They have read now so much of Chat GPT and all, everything is there. AI is there. So they all know that it's not working. So they are not coming.
Initially, so it was all if you have if you are an elite, then the first question, Acha, have you stored your child's, cord blood?
But आजकल नहीं होगा ये.
नहीं.
आजकल नहीं होगा.
खत्म हो गया ना.
कम हो रहे ना, आ नहीं रहे हैं.
एक दो आते हैं, एक दो आ जाते हैं कभी कभी भूले भटके खुद ही से करते हैं.
डॉक्टर प्रभु ने बता दिया सबको.
Dr. Prabhu,
it was a wonderful talk and very good presentation. How to make, how to inject. It was beautiful.
And
thank you, sir.
Please, everybody wants to get rejuvenated. So please tell again the exosomes, the protocol for the rejuvenation. Once only, and how to get it done and where we can get
one
it.
injection, so we can take the 70 to 80 ml of the peripheral blood, convert to the high leukocyte, and then we will prepare the exosomes, have the IV. So it's giving the all anti-inflammatory revitalizing.
So what?
Can you speak a bit slower, Dr. Prabhu? I've not caught on this.
Ma'am, take there is a prerequisite. So definitely either you are doing for anti-aging, we always give the vitamin D3 and GCSF 48 hours before.
Okay.
And then we are taking around 60 to 70 ml of the peripheral blood, making the high leukocyte PRP, then making the exosomes from that high leukocyte PRP, and that exosomes you can have the intravenous injections for revitalizing. Even you can see the changes into the all your lipid profile, OT, PT, etc. It brings down the changes. So it's biologically you can prove like this was this and this is it's brought down to this OTPT. We have seen 300 OTPT. It came down to 30-35. And then after that, ma'am, that nutraceutical IV we combine 8 injections.
So it is given once only, sir?
Rejuvenation.
Yeah, exosomes 1 injections, and then you can have like twice in a week some nutraceuticals like vitamin C 5 gram, magnesium, calcium gluconate.
That nutraceutical injections we are doing at our hospital. That we are giving all these injections.
And just you can combine with that. So you will have like your biological clock 10 year you can set. So there is a 2 age, biological age and the chronic chronological. So definitely you can reverse your biological age.
Yeah.
One query,
Prabhu,
Dr.
Thank you.
Prabhu.
So
one
should
thing
I
I
call
want to
you
say,
the father of the
Dr.
stem cell
Prabhu, you have a
Yeah,
Taj picture at
at
the
least
background.
in this
Can you
room.
tell me why?
Yes.
Ma'am, no, actually, like
Thank you.
they
Thank
made
you, Dr. Prabhu, for
Vandana,
accepting
let him
our
answer. I've asked
invitation
him something.
and enriching us. Yeah,
Vandana, Dr. Manju Verma was asking a question.
some network problems.
हाँ.
मैम सी एक्चुअली वी डू दिस इंटरनेशनल कॉन्फ्रेंस ना, सो ये कॉन्फ्रेंस का बैनर
Okay.
बना हुआ था, तो इसीलिए उन लोगों के लिए, गोरे लोगों के लिए बैकग्राउंड में ताजमहल डाले हुए हैं.
So it's
Okay.
representing India.
Yeah.
Of course.
नहीं उतना ही खूबसूरत रहना जितना ताजमहल इतनी शताब्दियों से है.
Exactly.
Thank you. This is the good explanation, मैम. अब मैं इसका यूज करने वाला हूँ.
Yeah. So, Dr. Chitra, would
Yes,
like
now.
to.
So very, very interesting conversation and very interactive session it has become. Thank you so much, Dr. Prabhu. And now I hand over the session to Dr. Anjula for Thanksgiving.
Yeah, thank you, Dr. Chitra. After this brainstorming session, I'm still into epigenetics and exosomes. So I have to come out of this. And first of all, it is really my privilege today to offer a vote of thanks at the close of this so insightful webinar and so interesting. On behalf of this organizing team, first of all, मैं ये कहना चाहूंगी कि किसी प्रोग्राम CME, whether it's a webinar or physical conference or anything, it has to be having a team, and that team has having a team leader. So first of all, it's my sincere thanks to the organizing chairperson, Dr. Vandana ma'am, that she has come out with this topic out of her brain of going to the next generation actually. So we have shifted to the futuristic approach. So from the core of my heart, I give you thanks, ma'am, for organizing this, giving this insight to the organizing team to work upon these topics. Now, next in the, I would really like to thank each one of the people who have participated. First of all, Dr. Sheila Mane, ma'am, who on our one click of the call, she's so busy. I think Dr. Chitradi has really made that effort to become the guest, chief guest of this webinar, and sparing her time and giving her valuable blessings and wishes for this webinar today. The next colleague, Dr. Pragya Mishra, was still not visible today in the whole of the webinar, but she has really participated throughout. If she's there still, she can hear me. She has participated and she has thanked the whole Prayagraj team. I think Dr. Sheila Mane ma'am and Dr. Pragya Mishra ma'am, this Prayagraj team is really, really bubbling with so many leaders behind what I can see. And really, it really makes us feel proud that Prayagraj is spread all over India. It has made really, our association has really made what you call in the hearts of everywhere we are still residing. So she has given those insights, thanking all of us. Now in the league, the experts for the session. Dr. Manju Verma ma'am, वो तो हमारी गुरु रही है हमेशा रहेंगी. वो बस बैठ जाती है और खड़ी हो जाती है तो सेशन शुरू हो जाता है. So thank you so much ma'am for guiding us always. Our chairpersons for the session, Dr. Sharda and Dr. Amrita, she was not able to join. And more than that, Dr. Ragini Dika, जो उस सेशन की स्पीकर रही है, I really love to work with her. उनका वो तो गुरु रही है हमेशा, और she is a lovable person, very down to earth, and accepts Allahabad is just like home for her. But she is so busy and she is the mastermind for webinars. I think she loves doing webinars. She was the person who introduced long day, full day ka webinars she introduced. So thank you so much, Ragniti, wherever you are and you are hearing, to core of my heart, I'm thanking you. And for the next session, the speaker, Dr. Prabhu, very dear to ma'am and Vandana ma'am के एक कॉल से उन्होंने इस चीज को एक्सेप्ट किया. She is also extremely busy, very nice person, and really I think Vandana ma'am would agree to me that she is an excellent person, very nice person. And on this topic, I think in India he holds the command. So hearing and listening to him every time is great. To the expert, Ranjana ma'am. She is also a very lovable, dear. मैडम के लिए तो हर चीज एक स्माइल है आपकी जिसपे हर चीज कुर्बान है, बस इतना ही कह सकती हूँ. She has been always जैसे होते हैं ना हर सोसाइटी के एक गॉडफादर, गॉडमदर,
फाउंडर पर्सन ऑफ दिस सोसाइटी. इस सोसाइटी की मदर है भाई,
मदर है. तो थैंक यू सो मच. एंड आपकी लीडरशिप से, फिर वंदना मैम की लीडरशिप से आगे भगवान करे इसी तरीके से सारी चीजें मुस्कुराहट होती रहे. एंड टू द चेयरपर्सन डॉक्टर वीना गुप्ता मैम, बहुत अच्छा लगा. शी पार्टिसिपेटेड एंड रियली टुक आउट इनसाइट्स फ्रॉम सच अ डिफिकल्ट टॉपिक. एक नटशेल में उन्होंने कंसाइज किया. डॉक्टर अमिता दी, you has been a very senior colleague to me and always very lovable. मुझे इतना उनके साथ मैच होता है और इतना अच्छा लगता है आप लोग सबके साथ. And giving me the opportunity to give vote of thanks on this day. None other less Dr. Chitra. Chitra Di, she has been an excellent senior colleague and organizing this whole, actually the webinar, calling up everybody, organizing, and the meticulous work she always does, and pinpoint kitni baar inhone reminders diya hoga, and the excellent coordination with all of us. Thank you so much. And the theme which came out from Vandana's ma'am, she gave a theme to this webinar. So this was a very good theme given, that gynecology, the next generation. So she framed that theme of the work. Thank you so much, Chitradi, for your meticulous thinking and conducting the program so well. Along with her, Manisha Di is always there as a guiding scientific expert of our society. She's always there, ever ready to do. एक क्लिक पे बोलती है मैं कर दूंगी ये काम. So thank you so much, Dr. Manisha, for joining us for this great webinar. And nonetheless, at the end, I thank the Jackson Pal, our scientific co-partners for this webinar, who has been, especially Nimisha, जिन्होंने Dr. Chitra के साथ पूरा coordinate किया है इस पूरे session को. And Nimisha, your technical team was excellent. We did not have, I don't think so, we had any kind of problem in this, either in the relay or either in the, even in the slide movements also. So thank you so much, everybody present. And at the end, कोई भी program बिना participants के नहीं होता है. To all the participants who have participated in this webinar today, I think they have really carried out a futuristic insight, and I would really tell Vandana ma'am and Dr. Chitra to come out with really good topics like this so that we are really rejuvenated. So rejuvenation is great. And I want all the faculty members to do a thumbs up so that we have a photo. And Chitra, they just take a...
Okay, I'll take it.
Yeah, I think we'll do a thumbs up for the rejuvenation of our ISOPARB society. Ranjana ma'am. Yes, that's great.
With Ranjana there, we are always rejuvenated.
Yeah.
Thank you so much.
Always.
And especially we got such a good foundation from Ranjana ma'am and Amita. And
yeah. I especially thank Dr. Manju Verma ma'am and Dr. Ranjana for being there throughout, like a, guidance for this.
Yes, let's wind up the session. Okay. Yeah. Okay, good night, everyone.
Good night. Have a nice day.
Bye-bye.
Bye-bye.
So thank you everyone for joining in today. And I thank ISOPARB Prayagraj team for making Jackson Pal Pharma as the academic partner. The session was today brought to you by Jackson Pal Pharma, the makers of Maintain Injection 250 and 500 mg. We have Divatron 10 mg and SR 20 mg to support natural and assisted conception. And lastly, we have Divagest SR for luteal phase support. So we look forward to your participation in the next webinar and have a good day, everyone.
Thank you, Mishra. Bye.
Thank you so much.
Thank you.